Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone, and welcome to Attitude Magazine's ADHD Experts broadcast. We hope everyone is staying safe and staying well. We are pleased to have Dr. Ellen Littman here to talk about how and why ADHD is different for women. Before we get started, let me note a couple of housekeeping items. Those of you tuned into the live webinar may download the slides now by clicking on the Event Resources section of your webinar screen. And if you're interested in the Certificate of Attendance option, look for instructions in the email you'll receive around an hour after the live broadcast. For those of you listening in replay or podcast mode, you can visit attitudemag.com and search Podcast 337 to access the slides, the webinar replay, and the Certificate of Attendance option. Now for today's topic, women and ADHD. ADHD exacts a greater psychological toll on women than it does on men, with more troubling long-term outcomes demonstrated in medical research. The psychological distress can gradually erode women's self-worth and quality of life. The good news is that experts today are creating holistic treatment plans tailored to women's needs. Rather than being silenced by shame, women are learning to trust their own voices. Dr. Ellen Littman will give us the perspective to better understand the challenges and how to manage them. Dr. Littman is a clinical psychologist licensed in New York State, educated at Brown and Yale Universities, the Clinical Psychology Doctoral Program of Long Island University, and the Albert Einstein College of Medicine. She has been involved in the field of attentional disorders for more than 30 years. In her private practice in Mount Kisco, New York, Dr. Littman focuses on high IQ adult and adolescent ADHD populations. She is co-author of the book, Understanding Girls with ADHD, now in its updated second edition and translated into several languages. You can ask questions of Dr. Littman, during her presentation, and she will answer as many as she can after she finishes. So with all that being said, I'll now turn it over to Dr. Littman. Thanks so much for being here today.
Hi, everybody. I'm so glad you're here and that you're interested. With so much information available on ADHD online, we may have a false sense that we know more about the experience of women than we really do. And I emphasize that we are constantly learning more and that there are plenty of controversies. The majority of studies on ADHD have used boys as subjects. If both genders were included, the ratio is usually heavily weighted towards boys. There is far less research on adults with ADHD and fewer involving women, and even fewer comparing women with ADHD to women without ADHD. So in other words, the study of women with ADHD is still in its infancy. What we do know is that as long as women with ADHD continue to be overlooked, they won't be subjects in studies. And as long as they're understudied, they're going to remain misunderstood and underserved. Until recently, the inner lives have been virtually unknown to us, and far too many still suffer in silence. So let's talk about why the struggles of these women have been invisible to so many for so long, and how we can help to illuminate their realities. Okay, if you join me for a quick stroll down memory lane, I want to illustrate why adult women, especially without hyperactivity, could not possibly have been diagnosed until now. ADHD is a product of its history. As many of you know, a century ago, disruptive boys were referred to clinics, and the earliest studies were based on the behaviors of those young, white, hyperactive boys. So only the rarest girls whose behavior mimicked hyperactive boys could be diagnosed. And so the assertion was that ADHD was a disorder that only affected boys. And that theory persisted into this century. So as those boys reached puberty, their hyperactivity began to wane. And so the assumption was that this was a predominantly male disorder, limited to childhood, and diagnosis required the presence of hyperactive symptoms by age 7. This is not a good setup for women. Until 2013, ADHD was classified as a disruptive disorder of childhood based on the hallmark of hyperactivity. The diagnostic criteria and assessment scales focused on the observable behaviors of disruptive males. So once it was established in 1980 that ADHD could be diagnosed without hyperactivity, the floodgates could be opened for girls to be diagnosed. And gradually it became clear that inattentive symptoms persisted longer than hyperactive symptoms, and that many cases of ADHD did not resolve at puberty and instead persisted into adulthood. And there we have women. So now we're looking at how we can improve our diagnostic accuracy, because we want to talk about why women have been invisible. So we need to shift our conceptualization from a behavior model to an impairment model. So we have to understand the complex functional impairments that compromise women's quality of life. And to date, this may be the most gender-inclusive way of understanding ADHD's impact, because women's experiences are not easily articulated or observed or categorized, and many clinicians don't know what questions to ask. So here's the head-scratching dilemma. The DSM-5, which is published by the American Psychiatric Association and used only in the United States, is a diagnostic manual that was updated in 2013, and it now includes 2 sentences on gender differences. Studies based on the DSM-5 criteria have concluded that there are no significant differences in terms of symptoms of ADD, severity, prevalence, number of symptoms, number of comorbid disorders, academic achievement, efficacy, and tolerability of meds. Okay, so in light of that finding, why are the outcomes so different? And we're going to try to look at the research that explains the very different experience of women with ADHD. Okay, so girls growing into women have a unique developmental trajectory. And it's true, ADHD doesn't differ by gender. It's the genders that differ from each other. They're biologically and neurologically different and are socialized according to different societal rules. It's only in the last 20 years that these concepts will have come together to characterize a really different picture of ADHD. Women have a greater likelihood of inattentive symptoms and less hyperactive and impulsive symptoms. And they're more likely to internalize mood and anxiety symptoms, shame, loneliness, frustration. And so that creates a much more subtle picture. The people who are familiar with the traditional hyperactive symptoms would be not seeing something recognizable. So we'll talk about why gender roles and compensating are so central to women's lives and discuss hormones in some depth depth because that research is really new and really interesting and really important. Okay. So these are risks that we find exist much more for women with ADHD, and whether compared to men with ADHD or compared to women without ADHD. So more emotional reactivity. And to a clinician of someone who might be very anxious, might have a mood disorder, because it is not yet classically a symptom of ADHD, but it is a very common symptom nonetheless and experienced by most women. Women also report lower self-esteem as well as more anxiety and depression and more psychological distress. And it's true that women with ADHD experience more anxiety and depression than men with ADHD. But the reality is that women without ADHD experience more anxiety and depression than men without ADHD. So hopefully the theme is going to become clear that the issue is not about ADHD per se, but it's about the differences in women and how that makes their symptoms play out very differently. Women also have been on more medications for depression and anxiety before they're diagnosed with ADHD. They have more long-term unemployment, more poor job functioning, and more histories that have physical abuse, sexual abuse, and neglect, which, of course, increase the risk of anxiety and depression. So these are some of the diagnostic challenges that we're trying to understand. Why don't more girls and women get diagnosed? And ideally, the earlier the better. So the first issue is about presentation. I hear constant reports, sadly, that women have been told, no, you couldn't have ADHD because you're a woman. You couldn't because you're so smart, because you did fine in school, because you're a successful professional. And none of these things preclude someone having ADHD, but clearly that is not a presentation that clinicians are familiar with. There are different symptoms, internalizing symptoms, and more inattentive symptoms. It's a subtle presentation and generally not at all disruptive. There are also comorbidities that further complicate the picture. And there's the impact of hormones that we're going to talk a lot about. But according to where in the cycle a woman is when she's meeting a clinician, it's going to look very different a week before a period than a week after a period. And if you don't know anything about that cycle, you won't have the context for what you're seeing. Another thing that is really unique to women is how motivated they are to camouflage their symptoms, and hiding is a big part of their presentation. So they are in some ways intentionally trying to not to be seen, and so it's a mixed bag. If they succeed, they don't get the help they need. And the symptoms that are observable are often anxiety related or mood related. And it is easy to see how if you're working from observable behaviors only, there could be a misdiagnosis. And there often is. The other aspect of the diagnostic challenges is about gender bias. Gender bias is not intentional, but it is insidious and pervasive, and it influences how we label what we see, and has certainly contributed to the limited and delayed diagnoses of females. Women's non-traditional presentation may appear less impaired, and inattentive symptoms rarely arouse concern. So many were never referred as girls or teens by teachers or parents or by primary care providers. Rating scales are still skewed towards male behavior symptoms based, again, on that history. And internalized symptoms are unaddressed, and many instruments are not normed for women's values. So we are still perpetuating the idea that it is much easier to be diagnosed if you look similar to hyperactive males. Women regularly feel that their concerns are not perceived as credible. And when I got involved in this field, I went to a conference, and the keynote speaker referred to girls as ADD wannabes. And this is not exactly where we are now, because that was the early 90s, but it's still a case where women have sub-threshold number of criteria, because those criteria are still very male-based behaviors. Girls would not be showing their symptoms until puberty, and we'll talk about why in a minute. So a cutoff at age 7 was going to mean that we would still not be getting too many girls picked up. So inattentive symptoms remain constant over the lifespan while hyperactivity wanes. And so it is why we have to start looking at a lifespan impairment model. And they need to be interviewed about the internalizing issues, because they're not tapped by rating scales. And they also need to have trauma-informed questions, because these histories have a huge impact on their ADHD symptoms. And unfortunately, the end result of being invisible is that they are less likely to be medicated, significantly less likely than men. Okay, so we're going to talk about hormones. So this is a really quick hormones one-on-one, this first slide, which is that not everyone is aware that the reproductive hormones, ovarian hormones, are also, the brain is a target organ for them, as well as a reproductive system. And in fact, those hormones interact with almost every system in the body, and they're essential components in physical, social, and emotional health for all women. And estrogen protects the brain by enhancing neurotransmitter activity, which then impacts executive functions, attention, verbal memory, sleep, concentration, motivation, in so many cognitive and emotional factors. I think not everyone is aware of how widespread the impact of estrogen can be. And that baseline estrogen levels change dramatically across the lifespan, starting from early puberty and on which there's a tremendous amount of fluctuation in adolescence, levels are very high during pregnancy. They drop precipitously in the postpartum period. And then perimenopause comes along faster than you think, around age maybe 38. And then gradually estrogen is decreasing until it's, out of your system by menopause. And since we're living longer, most women spend more than a third of their lives in menopause. So we have to talk about what it's like to live without estrogen in your system when it has such a central role in ADHD. Okay, so this is the impact of estrogen on ADHD. And the first thing to know is that symptoms vary with hormone fluctuations, which means that they can vary almost day to day because hormones fluctuate. I mean, it is not, just they go up and they go down. There are daily mini fluctuations. And some people, especially the more impulsive women, are very sensitive even to those micro fluctuations. And estrogen, I think I mentioned before that we don't really start seeing the blossoming of symptoms in girls unless they're extremely hyperactive until estrogen starts being present in their systems, which happens around puberty. And so, by the time you see a 14 or 15-year-old girl, they're experiencing a lot of emotional volatility and anxiety. And this is a primary time where they may be misdiagnosed and mismedicated. And let's see. So the other major piece is that ADHD symptoms increase as estrogen decreases. So estrogen decreases after ovulation, the middle of the cycle, and then gets lower and lower as you approach your period. And then the combination of low estrogen and high progesterone exacerbates symptoms tremendously. And that is actually just shortly after ovulation. And as I said, the impulsive women are sensitive to each of these changes as well of the change from high progesterone to low progesterone. So the point is that these estrogen and progesterone affect your symptoms of ADHD. ADHD is thought of as something that has stable symptoms across time. And the fact is that that's not the experience of women and their bodies. And that's a big deal. So what are some of the things that, we need to think about when we're considering hormones in treatment? So one thing is that the stimulants may be less effective in the second half of the menstrual cycle. And there are people who actually will make a small increase in the stimulant level during that last 10 days of the cycle. But it's important to be aware. Lots of people say, I don't understand it. My meds are just not working today. Well, in fact, they might not be working that day because of the change in hormone levels. Many women are prescribed SSRIs for anxiety and depression that are some of those internalized symptoms we talked about. But it's just important to know that they can be a trade-off. They certainly do help with anxiety and depression, but one of the ways that they do that is by making the thinking less rigid, which has a side effect of disinhibiting. And many people with ADHD are just struggling to inhibit their responses. So it's important to know that there can be this undermining side effect where it may be harder to inhibit. your reactions, but you may feel less anxious and less depressed. Oral contraceptives they really work for stabilizing hormone levels, and that can regulate a really unpredictable cycle and just keep estrogen levels under the bell curve. And it also can improve depression and acne. And so there are many people using these pills for that purpose. Hormone replacement therapy, HRT, increases estrogen and progesterone in postmenopausal women, and it greatly improves ADHD symptoms and also prevents menopausal bone loss as a perk. So the point is that there are so many ways that there are interactions between the hormones and the way ADHD symptoms are experienced by women that it really needs to be taken into account when you're choosing a medication regimen, if that's what you intend to do. And so the implications of these hormone studies, and I do want to say that there aren't that many studies, and this is all pretty new and cutting edge, and you may know more about it than some clinicians at the end of this talk, that daily symptoms are affected by hormone fluctuations. So whereas it has been thought that ADHD is in state versus trait, things that they stay stable across time, or state things that change across time. It was thought that it was a trait, that it stayed pretty stable. But the reality is it stays pretty stable for males, and it really is not stable for women. Women, it is it's a changing state. And that is a very different way of thinking than we have even considered before. So since we're understanding how different women's experience can be, you can understand that comparing women's findings on any given study to men does not necessarily make that much sense. It's not that men are the precedent, which is how it's been based on the historical gender bias. It's just apples and oranges, and we have to compare women with ADHD to women without ADHD in order to get a sense of how their experiences vary. And so clinicians need to be able to ask questions about hormones. Where are you in your cycle? Are you in menopause? If you were pregnant, how long ago were you pregnant? Things that would illuminate the hormonal cycle issues. And just that future studies need to include hormonal data, or we're still going to be missing a lot of information about whether how can we understand that woman a week before her period who may be crying and overly sensitive and maybe even a little paranoid and hopeless, and then a week after a period being confident and together and organized. There has to be a way of understanding how those two views coexist, not just in one or two women, but in all women, essentially. So the next huge reason for a very different presentation of women is about gender role expectations. Women who are able to conform to expectations do. Our society's gender rules require deference, empathy, cooperation, efficiency, organization, and the sacrifices necessary to always put others' needs first. And then if you can also go to yoga, it's great. That's a lot of expectations. And the women who thrive with that juggling act are unicorns, because that role demands a perfect choreography of the executive functions. So women with ADHD are definitely not wired for the unrealistic demands of such an overwhelming job. And yet somehow they're determined to manage self, family, and home. Craving social acceptance, they camouflage their problems from family and friends while they fear being discovered as an imposter. They doubt their competence and compare themselves harshly to their peers. Shame and stigma makes them unwilling to share what they perceive as failures or to ask for help. So to understand women with ADHD, clinicians cannot underestimate the extent to which women measure their self-worth by their success in conforming to gender expectations. Another area that is much more troubling for women than for men is the area of socialization. Women with ADHD are often overwhelmed with the demands of relationships. They tend to have fewer meaningful relationships and rarely initiate friendships and have trouble maintaining them. There's a lot of less stimulating maintenance that's involved in checking in with friends. And it's difficult for them to connect in a timely way, and friends easily fall off their overcrowded radar screens. Rejection sensitivity, which is a phrase that has been around lately, describes an intense emotional response to real or perceived rejection. And many women with ADHD feel judged, misunderstood, and expect criticism. So this is sort of an offshoot of emotional dysregulation. And but it's one that most women, I think, experience and find to be one of the most undermining aspects of their impairment, because they have, large overreactions or reactions that people may perceive as overreactions, but it doesn't seem to be in their control. Females discover very early that sexuality is a shortcut to social acceptance. It's common to find a history of early initiation of sexual activity, early intercourse, more sexual partners, more casual sex, less protected sex, more sexually transmitted infections, and more unplanned pregnancies. This is tremendously common, and yet often another experience that fills people with shame. And so most women with ADHD start out hiding their difficulties. And when they find that this works, it often segues into an avoidance of overstimulation, withdrawing from social situations that might be uncomfortable. And some women finally find that the greatest security is in just isolating themselves from interactions that are confusing and overwhelming. And but while isolation does protect them from the pain of judgment, they also never get to be truly known. So these are central nervous system hypersensitivities. And while men and women with ADHD have them, women have more of these particular sensitivities, more tactile sensitivities, which makes them uncomfortable with lots of different kinds of touches. Sometimes people just touch them too lightly, even if they're trying to be affectionate, and it's really annoying. Many people try to hug someone and then they sort of stiffen up and don't understand why they're having that response, but it's really about the actual sensory overload of the touch itself. And then, of course, it includes the more classic tags in the back of clothes, tight waistbands, hair in their face, wool sweaters, things like that. More somatic complaints for women. Lots of headaches, including migraines, stomach aches, nausea. And many women wake up in the morning with, some of these kinds of somatic discomforts. And it's really not until their brain engages in something else that it really starts resolving. Women with ADHD are 3 times more likely than women without ADHD to have insomnia. And that is certainly a big problem. And then being tired, it all feeds on itself. If you're tired enough, it interrupts your concentration. It's more depressing. It makes you want to eat carbohydrates. There's a lot of bad stuff about it. And ADHD brains respond to the highest level stimulation, and pain can really distract the brain from other activities. And women with ADHD seem to experience pain even more intensely than men, and they have a higher likelihood of fibromyalgia. And so they're struggling with pain for a lot of their waking hours. And other sensory problems include sounds like loud music. A very common complaint is listening to people chew. Freaks out a lot of people. Forks scraping on plates. Sensitivity to changes in light. Not necessarily a full seasonal affective disorder, but just, around end of October, beginning of November, a lot of women with ADHD find their moods starting to go down. And then also sensitivity to odors like perfume and gasoline. Those are problematic. Incense in new agey stores also can drive them out screaming. Okay. And then there are comorbid, coexisting issues that the longer that you're going undiagnosed, the more you're developing other ways of managing your symptoms. And by adulthood, most women have at least one comorbid disorder. It doesn't have to be a disorder. So emotional dysregulation is the most common one we talked about before. And anxiety and depression are the main ones that most women end up dealing with, followed closely by eating disorders of some sort, and externalizing disorders, which is found primarily in more impulsive women, and that would be something like oppositional defiant disorder, conduct disorder. Certainly males have more externalizing disorders than women. But if you compare women with ADHD to women without ADHD, the percentage of how much more likely they are to have externalizing disorders is actually a higher percentage than comparing ADHD men to men without ADHD. So it's an important factor as well. And then there's also personality disorders, with borderline personality being the most common, but also paranoid and histrionic, passive aggressive, and dependent. But borderline is a pretty common comorbid issue. And all of these things just complicate the symptom picture so that when you're talking to a clinician, it is just not pure ADHD symptoms about being distracted and having trouble with time management. So it's just a very different picture. And then we have the role of impulsivity. So impulsivity tends to make people have more gender atypical behaviors. So behaviors that others may perceive as controlling or demanding, or projecting blame, or being angry, that are just less familiar to be seen in women. They are also more likely to participate in high-risk behaviors like speeding, extreme sports, hypersexuality. More addictive behaviors like nicotine, alcohol, opioids, marijuana, compulsive shopping. And what we're finding is that estrogen actually interacts with these addictive behaviors, making them much more potent problems. And a study done about nicotine showed that for women, when estrogen was in their system, they started smoking earlier, they smoked more, they smoked more often, they had a harder time stopping. And I think as we go through all of these substances, I think these studies are going to be finding that everything that increases dopamine is also related to estrogen levels. So again, the centrality of the hormone involvement is just amazing. And we talked about eating disorders, but impulsive women tend to have more bulimia than other types of eating disorders. And they're more likely to self-harm. And this is a big deal, whether self-harm is picking skin, picking cuticles, cutting, burning. It tends to peak in early childhood, and more impulsivity usually predicts more self-harm, which is significantly more likely than in women without ADHD. And so ultimately, these are the outcomes that I was referring to. Here's why this is also important. The stress of constantly feeling less than, of expecting criticism, of feeling overwhelmed, frantic, stupid, of fearing rejection, of being unable to explain why your brain won't listen to you. These can become toxic ruminations that grow over time until they begin to block out the sunlight. And there are a number of ways in which this gets expressed. Women tend to not take as good care of themselves. They're not motivated to take care of themselves, even if they're responsible about caring for their children. But whether it's not watching what they eat and becoming overweight, or developing diabetes, or periodontal problems, or avoiding wellness checkups like mammograms. There are lots of different ways in which self-care poor self-care over time can be very undermining to your health and your life. We also find that undiagnosed women have a 2.5 times greater chance of developing major depressive disorder than women without ADHD. And those with a childhood history of ADHD, which is usually shorthand for maybe they had some hyperactive impulsive symptoms, in addition to depression, have the greatest risk of suicide attempts. Intimate partner violence, which is women with a history of childhood ADHD, who have a significantly increased risk of physical and psychological victimization in their relationships. The risk is increased if they've had abuse in their childhoods. And those with low self-esteem may also come to believe that their symptoms may make them less lovable and accept abuse as the necessary price for a relationship. And then we talked about the idea of self-harm, which is extremely common, and suicidality, which is also extremely common, especially in the more inattentive group. But, the despair and demoralization just keep growing. And if you, include isolation so that it just becomes an endless loop of rumination. And now what we're finding is that there's even earlier mortality for women with ADHD compared to men, and certainly compared to women without ADHD. And impulsive women, again, have the highest risk of an early death, with accidents being the most common cause. And, substance abuse would increase the risk further. And accidents are, I think, driving, or even people just rushing frantically and falling, and common breaking ankles, breaking feet. It's a lot of risk. Then you have high cholesterol, obesity, substance abuse. All of these can contribute to a death that could be earlier than others by maybe 9 to 12 years. And that's really hard to get your head around. And this is really recent research. So I don't know how much more startling these outcomes need to be before the concerns of women with ADHD get the attention they deserve. But I hope I'm getting your attention with it. And finally, so what can you do about this? What kinds of treatment considerations are important? And I hate to say that the first thing is the most important thing. Find a therapist who gets it, but it's also the most difficult thing. And I wish that I could say that there are lots and lots of clinicians and primary care doctors and other mental health clinicians who know a lot about women with ADHD. But there aren't that many, and it takes hard work. And if you're not in a big city or near a big city, it's even harder. And yet it is really the most important thing. If someone says, no, I know about ADHD, that's really not good enough. You have to ask how many women they've treated. And if you feel like your concerns are minimized or not validated in the first session, please don't go back. And it's important to try to find someone who will get who you are and what the struggles are. And then family psychoeducation, which is that it's not just good enough for you to know about this. It's really important that your support network gets it. So that's everybody in your family and maybe a friend or two, so that you have the support of people who understand what's going on. And the therapist can really help with the things that really can help you, which is questioning your societal expectations and focusing on your strengths and forgiving yourself and feeling entitled to boundaries and communicating directly, practicing self-advocacy. These things cannot be learned on your own, and it's good to have a guide along that journey. They can also help you learn to restructure your home in a more organized but ADHD user-friendly way, which usually helps women a lot. Medication can be very helpful if you choose to go that route. But again, you have to find someone who is aware of the hormonal issues and knows about really medicating women with ADHD, and coaching helps everybody with ADHD, and online support groups because they you can be anonymous if you want to, or you can make yourself known. But in any event, it will normalize what your life is like, and you'll have other people who really get the way you're living. And I think that is one of the best things that can happen. The point of this webinar is that it's essential for you to be well informed. Be armed with the facts and don't allow your perspective to be dismissed. Your voice needs to be heard and your experience validated. I hope this information can help you by empowering you to get the help you need in the pursuit of an unapologetically authentic life. That's what I wish you all. Thank you.
Thanks, Ellen. That was excellent. We have lots of questions, way more than we can answer, but I'll try to filter them for the ones that have been asked the most often. One is, a lot of women want to get involved in studies on women in ADHD. Is there any information you can pass along to them on how to get started?
Well, that is certainly music to my ears because, as I said, there are certainly not enough subjects out there that so we need them. My recommendation is to contact the university settings where they're studying ADHD in New York, Mount Sinai, and NYU are two sites where they're always doing studies. Mass General in Boston. I'm in New York, so those are the areas I know, or the University of Pennsylvania. So it's about contacting one of those university sites. They have studies going on. They'll be thrilled to hear from you.
Okay. Question, can ADHD develop in adult women, or is it most likely that it has been there since childhood and was overlooked or not recognized?
That is one of the controversies that I referred to in the very beginning. I think that my experience, my clinical experience, is that there are women who don't really experience symptoms until perimenopause or menopause, which also usually intersects with children going off, empty nest experience, reevaluating life, a lot of changes at that time. And so I think that those are high functioning people who were able to coast by for a lot of their lives when they had structure and estrogen. And, so my answer is it probably has always been there. But there are certainly people who feel that there is an adult onset ADHD.
Mm-hmm. You had mentioned about assessment scales, rating scales. Is there a particular assessment scale that you recommend to ensure that capture a women's range of typical symptoms and impairments?
Well, unfortunately, there really isn't anything like that. I mean, I guess to give ourselves, it's actually only a quarter of a plug, because we do have in our books, Kathleen Nadeau and Patty Quinn and I, scales that are not normed at all. So they do tap into those questions, but they can't be used diagnostically. There is, Margaret Weiss has a functional impairment scale that I think comes close to capturing some of those things. But unfortunately, diagnoses are made based on the criteria on DSM-5, and those are ones that are not very user-friendly for women. So we're working on that right now, a great new assessment instrument, but not yet.
Mm-hmm. What about thyroid issues in ADHD? It's been asked a couple of times, and how the interplay between hypothyroidism or hyperthyroidism and ADHD symptoms. Any thoughts about that? Any studies, research?
There is incredibly minimal research. I definitely know that there is a big correlation there. But in the, as I was saying in the beginning, what we're learning all the time, we can't always answer the why. Why are those things related? Or, exactly how, and even which one triggers the other one. But there is no doubt that women should be getting evaluated by an endocrinologist. Since we're talking about hormone levels of all sorts, it would be really helpful to take a look at the T3 and T4 levels as well.
Several people have asked about how all these, the lack of sufficient treatment and the ignorance about hormones and ADHD, how does that affect women in their careers? Do you have any research on that versus men?
About how the hormonal issues?
Well, the fact that it's not being sufficiently treated in a lot of cases, what does that look like in a woman who has a career? What might she start to see or experience in her career?
Well, yeah, I mean, that's the problem is that, I mean, without this awareness, you're going to suddenly be experiencing, greater concentration problems, more distractibility, a lot of problems with verbal memory, which, in a work setting is really problematic, and more mood problems and emotionality. And you won't be able to understand why. So if you start feeling any of these things, I mean, and women often say, I don't know, I'm crazy. I imagine that. And, this is really a theme that gets worse and worse. So the best thing that they can do, I mean, is at the first signs, talk to an endocrinologist or even their gynecologist as a way of addressing some of those needs.
Mm-hmm. A lot of women here, and not surprising to you, have brought up the fact that they don't feel that their male clinician, doctor, whatever, is capturing or even aware of a lot of what you brought up. A lot of them want to educate their clinicians. So do you have any wording for how women can bring up their cycle and medication interactions with their doctor? Might there be a way to broach that conversation?
Well, absolutely. I mean, that's sort of, the sort of radical intent behind this talk is that you all know more about it now than many clinicians do. And I've actually had clinicians call me and challenge me on this from Mississippi, and I had someone from Iowa, and so you can literally send articles. You can send my articles. I mean, you can send the original research articles or, summaries that I've written up, but it is really important to not back down on this and not to set, because I have been told that the reason that they don't follow up with hormone levels in terms of where in the cycle people are to match subjects is because it's time consuming. And that's probably not a good enough answer for the fact that this is really can destroy people's lives. So they have to insist that it's an issue. And, there are we have just the beginning of articles that you can refer people to so that it won't get dismissed. Mm-hmm. But I would also be lying if I didn't say that, I've been pursuing this issue about females and ADHD for 30 years, and it's slow going.
Yeah.
So I'm just saying that it isn't like all clinicians will just say, "Oh, I get it now." A few more each day, but nonetheless, carry your torch high and do what you can.
Mm-hmm. Well, I think the hour is up. That was excellent, very insightful. And thanks so much for being here and sharing your expertise. It opened my eyes quite a bit. So, and I'm sure the audience as well. So thanks again.
You're welcome. I'm really thrilled to be here, and I hope this was helpful to everybody. Thank you for having me. Thank you, Attitude, for being aware that this is a really important issue.
And I just wanted to thank all of the attendees for joining us, and have a great day.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com.